to get rolling here. I'm going to talk today about acute disseminated encephalomyelitis, which has been referred to many times, largely a disease of children. And I'm going to talk about acute transverse myelitis in children. What is ADEM? I think you all know by now, but I don't. The reason I don't is because, there are really no clear diagnostic criteria. And yesterday you saw many times this diagram that we refer to in transverse myelitis all the time, which was developed out of the working group. We need to do that in ADEM. And just this month in the Journal of Neurology, the entire supplement was devoted to pediatric MS. And there's one article in that journal on ADEM and why we need to get national MS centers that have pediatric centers so that we can get these rare diseases basically defined and then begin to study them. Speaking of studies, there are really essentially no prospective studies in ADEM or transverse myelitis, unfortunately, in children. They're very small cohort sizes, and that really limits our ability to tell you anything useful from them. We don't know if it's just anecdotal, in other words, it's just coincidence, or whether it's really a true association between the findings. There are also very short follow-up periods. So children come in to the hospital, especially here in New Mexico, where we're a referral center. We see them, we diagnose and treat them, and then we send them back to their communities. And sometimes it's just a 5-hour drive to come in here. Well, you're doing fine. It's not worth it. So that is a problem. I'm trying to do too many things at once here, as usual. Okay, so what are the clinical features? Well, it's acute. That's why it's called acute. And it has an encephalopathy, which Dr. Barnes talked about yesterday, and I think Corey did, someone else did too, mention that. Basically, that means that your brain, overall your cognitive function, is not working right. You are either confused or you are maybe even a little psychotic acutely. So if you have a normal child and they present this way, I think most parents actually realize something is wrong. One boy who was flown in from Los Alamos here came in and they said he either has Guillain-Barré or transverse myelitis. So when we examined him, we went to examine him. A couple of hours had passed since we'd heard the story from the referring doctor, and we could not wake him up. Why couldn't we wake him up? Because he had transverse myelitis, but he also had ADEM. So he was just wanting to sleep through this whole process. Interestingly, he had had a previous episode when he was 2 after a viral illness where he had to have eye surgery because he lost function of one of his eye muscles. And I don't know whether he ultimately developed MS or not. At any rate, ADEM is often preceded by a viral infection. This is hard. Okay. So what is ADEM? Well, it's a lot of different things. There are many variants, as was mentioned yesterday. They all have mental status changes, but if they don't, it's called a clinically isolated syndrome. And guess what? Transverse myelitis is actually a clinically isolated syndrome, and I'm going to talk about that later. It's monophasic or phasic. In other words, it has a protracted single episode that kind of has ups and downs. It could be recurrent, so you have ADEM and then it comes back after treatment. Sometimes when you wean steroids too rapidly. It could be multiphasic, so there are different variants of this, and then some of them become steroid dependent. So here you have a beautiful little child, and they have to take steroids basically for years. And there are a lot of consequences, as any of you who've been on steroids know, if you use them chronically. And then there's ADEM plus a later demyelinating event. The case I described, he probably had had a preceding acute demyelinating event of the boy we couldn't wake up. In this case, this would be ADEM and then maybe an optic neuritis or something that occurs later on. So what are the things that make it more likely that you might get a relapse in this disease? So if you have optic neuritis with your initial episode, you have a higher risk of having another episode. If you have a family history, as we were talking about genetics, very important part of medical care now. you have a higher risk of having another episode. And then if you have Barkov MS criteria on your MRI, so in a lesion that might involve the corpus callosum, different anatomy than what we usually see in ADEM. And then the good prognostic sign, decreased risk of relapse, is if you have no residual findings after your first episode. If you're completely well after your first episode, there is actually a decreased risk of relapse. And you've seen scans before. Just to point out for you, this little bright area here is where the money is, and over here. So that is a fairly typical lesion for ADEM. It usually involves the white matter, not so much the gray matter, but can involve deep gray matter. Okay, and what is the epidemiology? What are the things that go along with this disease? It can affect any age, so it occurs more often in children, but you can get this as an adult. It can often follow an infection, as all of these diseases we've been talking about do, or it can follow an immunization. So I know there's a lot of people in the audience that are very concerned about vaccinations and immunizations. So we know for sure smallpox or rabies, but there are other immunizations that it can follow. It may affect slightly more males than females, and this is different than the other diseases. Almost all the other diseases are much more likely to affect females than males. And the mean age at presentation is actually only 5 to 8 years, so this is definitely a younger set. And the incidence is still very low in children under 20. There is a seasonal distribution reported in some series of this disease, and it tends to occur more often in the winter months. And why would that be? Viruses, winter viruses, that's right. All right, so this is a really interesting new study. This is a study that just came out in the American Journal of Pathology, where what they did was they took, can you move it? Won't move forward? They took a mouse that was genetically different than other mice, and that's why it has this little string of DNA on its tail. And these mice already have an antibody against one of the brain proteins called MOG. But normally these mice are pretty healthy. They don't get any disease. But then they infected them with 3 different viruses. And the viruses they chose were hepatitis, this encephalomyelitis virus, and then a Coxsackie virus, Coxsackie is a very common winter disease. And what they found, you could move to the slide, was that they developed ADEM, basically. So they just had to be susceptible, then they gave them these viruses, and then they developed this syndrome. And this is a case, actually, the top case here is from a human, a man who is 70 years old. He got an immunization against influenza. And then he developed this disease and died of aspiration pneumonia and infection. He didn't die specifically of ADEM. Did you have a question? No. Okay. And this was his autopsy. So these were the findings that they found after he died, and they examined the brain. And basically, you see classic signs of what you see in these post-infectious and demyelinating diseases. So you see something called perivascular cuffing, which is here, where these are too many cells around these blood vessels here. I'll show you over here, right there. And then you also see swelling. So there's areas where there's too much water. Forget that. I think I killed this. And in the right-hand corner, on the bottom, these were the animals that they did in their experiment, where they had these genetically susceptible mice. They gave them an infection, and basically they look very, very similar. They lost myelin, they had perivascular cuffing, and they also had edema, they had swelling. sometimes the swelling can be so severe that you could actually die. So it's a serious component of it. And this is the spinal cord here on the bottom for those who are interested in transverse myelitis. And it showed very similar findings as well, with too many cells in there, loss of the tissue, and injury to the spinal cord. All right, so the results in the end of this very interesting new study show that infections, the possibility that infections can lead to much more profound immunopathology in the presence of an already autoimmune condition. So what does that make us think of? That makes us think that if you got ADEM, or perhaps even some of these other diseases, that maybe you're already genetically susceptible. Maybe you're already just waiting for the right virus to come along, and then your body is going to react to it in that way. All right, I'm going to skip this slide. It's way too complicated. So, but why is it that ADEM is more common in children? We really don't know. In this study, there was a hypothesis, a theory, that what was going on was that because the myelin, which is what is mostly attacked in ADEM, was not mature, wasn't the same as adult myelin, that that in itself, that the myelin not being mature yet, was what predisposed you to developing ADEM. So the right virus comes along and your myelin's not mature yet, and so you react to it in this way. So what they did was, Dr. Ford mentioned a study called spectroscopy, and they took patients and they put them in an MRI machine, and then they measured the specific chemicals in the brain. And what they showed you in these little boxes here, try it again, right here and here, was that they found, these are normal findings here in the brain. They're called choline and creatine. And what they found was citrulline, which is like an amino acid, actually was not supposed to be there. That little peak there, sometimes this works and sometimes it doesn't. Right there and right here was found that was too small to measure, and so there's a question whether it's actually real. And this was just a section here where they found normal findings. They didn't find that little extra divot. And so it's an intriguing theory. Let me just show you over here if I can. I can't even see that from this angle. There's between the two big peaks, there's an extra little notch, and that is citrulline. They also measured it in the spinal fluid, because you know when people come in, we do an MRI and then we look at their spinal fluid, and they found that citrulline was also increased 2 to 3 times what it was in the normal controls. All right, so now we're already, so you've come in, you got your diagnosis, we woke the boy up, we did the MRI, we found out that he had multiple lesions all over the place. Now we need to think about what are we going to do to treat him. So the question is there an effective ADEM treatment? We have that same question in every one of these diseases. Well, we really like to have data, and we don't have any. So there are no randomized controlled trials, which is the gold standard in pediatric or adult ADEM, only case reports and case series, and all of these are based on patients who've already had the disease. You're not measuring it from here into the future, and that really changes the validity of the evidence. But they've been using corticosteroids. I bet you're surprised to hear that. Steroids were first used in 1953, at least as far as medical reports, and they gave an injection called ACTH. Has anyone had ACTH? They used to use it in MS, and sometimes we still do.
For asthma when I was a kid.
Asthma, okay. So, but we do use it in childhood now for very severe epilepsy, but it's not used much at all. Thank goodness, because it hurts a lot when you get those injections. But prednisone, other forms of corticosteroids have been used. And there are case reports and case series in which they report marked improvement. The typical dose is 10 to 30 milligrams per kilogram per day for the doctors in the audience, with a maximum of 1 gram or 1,000 milligrams per day. The duration of treatment, how long we do it, is not really known. But most of the time we say, let's give them that blast for 3 to 5 days, and then you can taper the steroids, just like you do in MS, for 4 to 6 weeks, just with oral medication. There is some thought, as I mentioned before, that if you go too fast on your taper, you may actually cause a relapse. And I love gammaglobulin, but there's only case reports of its use in this disease, so it's not really very good evidence. There are no direct comparisons of gammaglobulin with steroids or plasma exchange in this, or even those other immunomodulatory treatments that we were talking about, like Cytoxan. There's, it's in most of the studies, the case series that have been reported, they've used pretty much the same dosage, which is 1 to 2 grams per kilo, as a single dose or over 3 to 5 days. What's really interesting is that there's very little evidence that this actually works, but a recent evidence-based report out of Canada recommends gammaglobulin in this disease, in ADEM. It's one of the specific indications. This just came out last week. All right, let's move on to transverse myelitis. So I care about the little ones. I think we all do. What is transverse myelitis? Well, it's acute or subacute. I know you've heard that before. It's an inflammatory disease of the spinal cord. That's it, nothing else. As far as we know, I know there's some thought that it may affect brain function as well. It's bilateral usually, but it's not equal in distribution, so we call that asymmetric. And from symptom onset, from the first thing that you have happen until you reach the maximum deficit, which we call a nadir, that's the first phase, called initial phase. And then there's a plateau phase where things don't seem to be moving up or down. Things are just stable. And then there's the recovery phase, and those are really variable. All right, so we looked at a number of New Mexico patients, similar to the study that Dr. Baratich presented yesterday. Dr. Lauren and I did this last year. We looked at the clinical presentation, and our question was, is it different between children and adults? And we looked at how we were diagnosing children and adults and their treatment to see if they were any different. We created a database, which is all fraught with a lot of frustrations. We compared the adult and pediatric cases. We looked at the number of diagnostic tests and the kind that they had, and then we looked at the published criteria from the Transverse Myelitis Working Group, and we compared whether our patients were meeting the same criteria. And then we looked at treatment, their outcome, and then their demographics. What was their ethnicity, their ages, and those kinds of things. So what I'm going to do now is just show you from the most recent study of transverse myelitis in children that had sufficient numbers, and they weren't very many, what they found and then what we found in comparison. So we found that in this Dufresne study, which I think is out of Belgium, published in 2003, they found that 88% of children presented with pain. Do we have electrical gremlins or what? And they found that a lot of them presented with fever. That question came up yesterday, and there was a very high incidence of fever in this study. Then, of course, paralysis and sensory loss, which is what really defines the spinal cord injury, and then sphincter involvement. And what we found was that 100% of our children and 90% of our adults had pain at onset. We found that 82% of our children had weakness, about 50% of the adults. 82% of our children had sphincter or bowel and bladder problems, whereas 40% of the adults did. And sensory changes, 100% in both of our groups. The nadir, meaning the lowest period, we found that 3 were quadriplegic of our children, and there weren't, we only had 11 children. 2 were on a ventilator, and paraplegic, so legs only, 45%, hemiplegic, so spinal cord on one side. We found 18%, monoparetic one limb, 9%, and bowel and bladder dysfunction, as we said, 82%. And those numbers differed between the adults and children. Then, epidemiologically, the incidence I can't report because we didn't have enough numbers to tell you what the incidence was in New Mexico. And, but we did find that there was a gender difference in, oops, I'll just wear this. We found a gender difference between children and adults. We found more males in, more females, I'm sorry, in the children, quite a lot more than we did, and there was the same different distribution, but the same differences in adults with by gender. And then on the right-hand side of the slides, I would point to it with my finger, is that we broke down children by age groups, and we found that there were sort of two peaks. We found 4 children under 4. That should be a less than 4. And we found 4 also between 15 and 18, and not so many in between. And then in our adults, we broke it down by 10-year intervals, and there really wasn't too much difference, except for the 61 to 70-year-olds. We had the most adults there. Let's see. Preceding illness, we had 64% of children had a prodrome. I'm going to try that one.
That center button is a laser, and there's your advance.
Oh, okay. All right, so 64% of children had a prodrome, did not have a prodrome, sorry, and 60% of adults did not have a prodrome. That means they didn't have that viral illness. Okay, so radiologically, what was different in the Dufresne Belgian study, they looked at single or multiple lesions in transverse myelitis, swelling, as I showed you on the pathology slides, and enhancement when we give the dye. When you get an MRI scan, did it pick up the dye? And then how many segments were involved, how many parts of the spinal cord were involved. And in their study, 2 out of their 6 were normal initially, and in follow-up, 2 out of 4 of their abnormal ones were normal. So 2 out of 4 then had persistent abnormalities after 4 months of age. It didn't completely clear. And in our study, sorry, too much technology here. There we go. And we found that it was limited to the C-spine in 18% of our children. C and T-spine. C-spine is cervical, your neck. Thoracic is your back, 45% there. And we found 1 segment of extension to 16 segments. So that's a very long lesion. And I'm going to show you a picture of a very long lesion here. This is where it starts. This is almost like the Devix that was shown to you yesterday. This is really hard to see over here. So it spans many, many segments. And what Dr. Lauren did is she took the segments. This is the cervical, thoracic, lumbar, and sacral. And so she looked at each of our patients here, 11 children, 10 adults, and she showed where the lesions were spanning. And what we found is that in children, many more cervical vertebrae or segments were involved than we found in the adults. So over here, the cervical section, much more commonly involved in children than it was in adults. Okay, and then the spinal fluid, which is part of almost all of our evaluations, increased white blood cells only in 20%. And 33% of adults, elevated protein in 60% and 78% adults. We didn't find any children or adults who had oligoclonal bands, which are seen in MS. So our question was, how similar was this to MS? We did find myelin basic protein in some of the adults, and then the IgG index. So both 1 child and 4 adults had that. And then outcome. So full recovery in 31%. In his study, in Dufresne's study, minimal sequelae 35% and mild to severe in 44%. So it's potentially a disease that can leave you quite disabled, as you know. In New Mexico, what we found was 46% had good outcome in children, 33% in adults. Those that could walk with a walker, 18% of children, 11% of adults. And then permanent weakness, 36% of children and 56% of adults. And then I've already shown you that. And treatment, what do we do about transverse myelitis? We don't have any randomized controlled trials. There are high-dose steroids that can be given, and basically the same dosage protocol, the 10 to 30 milligrams per kilogram per day for the doctors, 3 to 5 days, and then weaning. Doug Kerr might disagree with that. And then immunomodulatory treatments, because we're talking about children who might be on a ventilator. We might have no movement at all, and it may go on for weeks or months. When we give one treatment that fails, we usually wind up giving all the rest that we can think of. So that's typically how we manage it. If we see a child who has mild involvement, we would weigh the pros and cons of treatment, but usually give steroids. And if they have apparently a good response to the treatment, begin to improve after the initial treatment, then we would probably just watch them. So we're learning more, especially with the Hopkins group guiding us, and I think that is going to come out in, I think the demographic data and findings from their database are coming out in about 2 weeks. Dr. Frank Piddock, 2 weeks? Yeah. So this is a study by Sabire, and this goes along with what Dr. Kerr was talking about, where there is increased IL-6 or interleukins in some of these, and what they found with steroids was that these actually were down-regulated, and that means that they could tell when they gave steroids to in an in vitro model, that means in a dish, they found that the interleukins were downregulated. They weren't as active. So, and they had done some preliminary work as far back as 1966. How are kids different? Well, turns out they have pain. That pain in the acute phase of transverse myelitis does not predict their outcome. So I told you about the outcome studies in ADEM. With transverse myelitis, in at least one study, that was a pretty good study, they found that pain did not really predict the outcome. It may be more common in children, although it's hard to get a grasp of those numbers. I just want to give you a little anecdote. You met Clarissa last night and yesterday, and I think this is okay if I talk about this, but she is more than a year out, and her mom, when I just saw her a couple weeks ago, said she's just gained biceps function over the last few months. So she is still getting better. Sphincter dysfunction may be clinically silent, in other words, bowel and bladder problems, because with a very young child, you don't know whether they're not even supposed to be toilet trained yet, so it's harder to tell if they're having problems. And so it really requires routine evaluation of that. That's very important in children. All right, so this is the Rio Grande Gorge, and this is rafting down the Rio Grande Gorge. This is my advertisement to come to New Mexico.